I'm really delighted to have us be hosting Dr. Amy Treece here for Duke Grand Rounds and also for Virtual Pathology Grand Rounds. Dr. Treece is an assistant professor of pathology, molecular and pediatric pathologist at the Children's Hospital of Colorado, as well as the medical director of the Precision Diagnostics Laboratory there. She had got her bachelor's summa cum laude from NC State here in Raleigh, and she went to medical school, full disclosure, with me at Duke. So this is in some ways a virtual homecoming for Dr. Treece. She then went on to complete her APCP residency at the University of Alabama in Birmingham, returned to North Carolina for a molecular genetic pathology fellowship at the Light Blue Institution down the street, UNC Chapel Hill, and then did her pediatric pathology fellowship at CHOP in Philadelphia. She is very active. She has won numerous honors and awards, including the Roger Denio Baker Prize in Anatomic Pathology from UAB, the Summit Award for Excellence in Teaching and the Education of Pathologists from the University of Colorado multiple times, 40 under 40 from the ASCP. She is in the Children's Oncology Group Young Investigator Program, and she is has membership in a number of professional societies. She serves on multiple committees within her hospital, institution. Nationally, she is a COG renal tumor committee member and a member of the Society for Pediatric Pathology Education Committee. She's done numerous invited lectures and presentations. She teaches medical students, dental students, pathology residents, fellows, and she has a number of peer-reviewed publications and abstracts. So I'm really delighted to have Dr. Treece here talking to us about pediatric renal tumors and a COG update.
Okay, thank you so much, Sarah, and thank you everyone for inviting me and having me today. I'm really excited to share some of my pet interests with you guys. As Sarah mentioned, today I'll be talking about pediatric renal tumors, particularly molecular diagnosis and some updates from COG protocols. And here we go. Okay, I'm not going to read through all of the objectives, but in general, we're going to go through 6 different tumor types and go over some of the more recent updates in the diagnosis and prognosis and molecular basis of these tumors. As I settled into my role in the Children's Oncology Group and started doing more reading about these pediatric renal tumors, I was really struck by how much we've learned really in the past 10 and particularly the past 3 to 5 years about these tumors. And so that's really what I want to focus on today. Before we jump in, I have no disclosures. So I just want to start with giving you some perspective about the rarity of what we're going to talk about today. So in a sea of adult cancer, pediatric cancer is already a rare entity. And then when we look at the subtypes of pediatric cancer, renal cancer is only about 5% of pediatric cancers total. And then we narrow that down even further because amongst pediatric renal tumors, Wilms tumor really takes up the vast majority. And only about 10 to 11% of pediatric renal tumors are non-Wilms tumors. And most of what we're going to talk about today falls in these categories. So really we're talking about the rare of the rare of the rare. And so you may be asking, why do I care about things that are that rare? Well, they do happen. And there are a lot of kind of pitfalls in the diagnosis of these tumors, particularly are because they're so rare, and especially general pathologists don't see these very often. And so I think it's important to call out how do we go about accurately diagnosing these. And in addition to that, they're really interesting. They have some really interesting molecular mechanisms, and so we're going to dive into these today. So our first case is shown here. This is a 12-year-old boy with a renal mass. You can see the gross image here, an irregular kind of yellowish tumor with some hemorrhage. Microscopically, this tumor is composed of kind of nest to papillary architecture of these large clear cells with relatively small nuclei. On higher power, we can see that the cells have quite a bit of very clear cytoplasm. Some areas it becomes more eosinophilic, and we have some psammoma bodies here. So this is consistent with a translocation renal cell carcinoma. So you guys from the adult side, I'm going to ease you into this because this is one that actually overlaps the pediatric and the adult population. Um, Translocation renal cells account for about 50% of childhood renal cell carcinomas and only about 1 to 4% of adult renal cell carcinomas. However, the numbers of renal cell carcinomas in adults are so much higher that the incidence is still much higher in adult. There's still a higher number of translocation renal cell carcinomas identified in adult patients. Overall, these tumors have a good prognosis in children, despite over half of pediatric cases presenting at a high stage. The survival is still greater than 70%. In adult cases, the prognosis is worse than papillary renal cell carcinoma, but overall similar to clear cell renal cell carcinoma. Overall, about 40 to 50% of cases have lymph node metastases, and that incidence increases with age. Translocation renal cells are known to present with very late metastases with reports up to 20 to 30 years after original diagnosis. So that's something important to know about. And these tumors do have a known increased risk following exposure to cytotoxic chemotherapy. So digging a little bit into the molecular, these tumors are also known as the MIT family translocation renal cell carcinomas, and MIT stands for microphthalmia-associated transcription factors. This family of transcription factors includes TFE3, TFEB, TFEC, and MIT-F. And the pathways that are associated with these genes and proteins are also involved in alveolar soft part sarcoma, picomas, melanoma, and other tumors. So translocation renal cell carcinoma most commonly demonstrates fusions of TFE3 that's found on XP11. And these account for about 93% of translocation renal cells. There is a smaller portion that is associated with translocations of the TFEB gene, which is found on 6P21. The TFEB gene has a pretty consistent partner known as MALA-T1. However, the TFE3 gene is pretty promiscuous, and there is actually a continually growing list of reported partners. The two most common are highlighted here, the PRCC and the ASPL. Interestingly, this third most common partner, the SFPQ, appears to be an evolving category of tumors that are located in the kidney and also in the soft tissue that appear to be of mesenchymal origin as opposed to epithelial origin. So I think this is something that's still evolving, so there's plenty to still be discovered about these tumors. This list of potential partners, as I mentioned, continues to grow. It's over 20 now and even includes an EWSR1 translocation. So between those TFE3 and TFEB subtypes, there are descriptions in the literature about differences in histology between the two. The TFE3 tends to be a little more papillary. The TFEB tends to be a little more nested. You can have the TFE3 with a more small cell kind of appearance. However, those histologic features are not sufficient for us to be able to determine, just based on histology, what the translocation partner is. There are some additional immunostains that can be somewhat helpful. The TFE3 subtypes are generally positive for PAX8, RCC, CD10. They're somewhat variable for cytokeratins and cathepsin K. They can also express melanocytic markers. And the TFEB subtype is actually more likely to express those melanocytic markers and less likely to express cytokeratin, CD10, and RCC. The TFEB subtype is also positive for the cathepsin K. So again, somewhat helpful, but there is still some overlap, and so not entirely useful for telling the two apart. So one thing that can be useful to identify TFE3 versus TFEB and also to confirm the diagnosis of a translocation renal cell is actually the TFE3 and TFEB specific immunohistochemical stains. However, these should be used with caution. So here's a picture demonstrating the TFE3 and the TFEB in cases that have been confirmed to have these translocations, and you can see that they demonstrate strong nuclear positivity for the stains. The caution I mention is because there are false positives, particularly in the TFEB subtype, due to overexpression of TFEB secondary to gene amplification. This renal cell carcinomas that have TFEB amplification are actually an aggressive renal cell carcinoma subtype that's seen in adults. And so this can potentially cause a false positive. Staining is also overall nonspecific. There has been positive staining demonstrated in a variety of different tumors. There's actually a difference between performance of the automated versus manual staining. So there's a subset of renal cell carcinomas that have ALK translocations that are actually positive for TFE3 by the automated method. There's also different performance between labs based on fixation time, how they titrated their antibodies, and other technical factors. So there was a relatively recent publication that looked at translocation confirmed cases of alveolar soft part sarcoma and XP11 translocation renal cell carcinomas. And between the two labs, you can see that there was a difference in performance. So 84% of the alveolar soft parts are detected in one versus 74% in the other, and 88% versus 63% of the translocation renal cells. So this demonstrates there's variability between labs, and these are not 100% sensitive or specific. So I just wanted to mention that the validation design is really important, and the literature recommends using actual cases that have been molecularly confirmed in the validation of the antibodies. So if IHC and histology are not 100% helpful, can we rely on FISH and reverse transcriptase PCR? So FISH is actually one of the ways that this is most commonly confirmed, particularly for TFE3. And for TFE3, we often use break-apart probes, and those are most useful because the TFE3 does have variable partners. So as long as we know that the TFE3 gene has been rearranged, that is sufficient for the diagnosis. Again, not 100% accurate because there are some false negatives that have been reported with TFE3 gene fusions that are actually due to inversions on the same chromosome. And because those inversions do not result in a split signal that is sufficiently split to detect by FISH, you may have false negatives by FISH. Reverse transcriptase PCR can be used, but it has to be designed particularly for the two partners. So it again will not detect all of those alternative partners. It may be only designed for the two most common partners. So ultimately, our best, if we want to capture all potential partners and capture both the TFE3 and the TFEB at once, the evolving use of NGS-based fusion testing is probably the way to go. Although I would imagine most labs still probably start with FISH for TFE3, or still utilize the IHC and maybe reflex to the NGS if those are negative. So I do want to mention a little bit of a COG update here. There has been some study into targeted therapeutics in translocation renal cell carcinoma. There have been some small studies that looked at c-Met and mTOR inhibitors that really showed no significant responses in these patients. There is now a COG trial, AREN 1721, that is currently open and has been open for, I believe, about 1.5 years now. And it looks at unresectable translocation renal cells, and it is taking enrollments from all ages. So they are also looking for adult cases as well, if your institution is interested in submitting cases. So this study looks at a VEGF-R tyrosine kinase inhibitor, as well as an immune checkpoint inhibitor in translocation renal cells. These therapeutics have been studied in other types of renal cell carcinomas, but this is the first time that a prospective study will focus on translocation renal cell. The study does require IHC, FISH, or RT-PCR confirmation of the translocation, and all of the cases will get retrospective path central review to confirm the diagnosis. Okay, shifting gears to our second case, much younger age group now. This is a 1-year-old patient with a renal mass. And you can see by the gross picture that this tumor has pretty much completely replaced the kidney. There is no real identifiable rim of normal even. This is a really aggressive looking tumor. By histology, this tumor shows sheets of these cells that you can see have pretty prominent nucleoli, even at low power. When we shift to high power, we see, again, those really prominent large nucleoli, round to polygonal nuclei, and cytoplasm that contains these pale pink cytoplasmic inclusions. Our diagnostic stain is shown here in the upper right corner, and this is an INI-1 stain that demonstrates loss of normal staining in the tumor cells. So this tumor represents a rhabdoid tumor of the kidney. These tumors also demonstrate patchy cytokeratin and other epithelial markers, and these cytoplasmic inclusions represent bundles of intermediate filaments and stain strongly positive for vimentin. So rhabdoid tumor of the kidney is a very rare, even in these rare tumors, is very rare in the pediatric population and accounts for less than 1% of the pediatric renal tumors. Most present under the age of 1, so this is seen in a very young population, and this is the most aggressive of the pediatric renal tumors. These present at a high clinical stage, and still, even with the advances that we have in therapeutics today, only have a 20 to 25% survival. These tumors can also be bilateral, or patients may have additional primaries in other locations, such as brain or other soft tissue locations. So the molecular alterations in rhabdoid tumors give us information about why we have that loss of INI-1 staining. Rhabdoid tumors demonstrate alterations of the SMARCB1 gene, which encodes INI-1, and that's located on chromosome 22q11. Looking at this region, if 22q11 sounds familiar, that's because that's the location of the DeGeorge or velocardiofacial syndrome region. And this is actually adjacent to the SMARCB1 gene. So you can see here, there's the DeGeorge syndrome, the proximal 22q11 deletion. This is the distal 22q11 deletion. And then right beside that is SMARCB1. Alterations in this gene come in the form of large and small deletions or duplications. They can be frameshift mutations, splice site mutations, and nonsense mutations. Ultimately, these are loss of function mutations, and in most cases, they are biallelic. And the subsequent loss of INI-1 expression that we see by IHC gives us a surrogate to be able to identify these tumors and the loss of SMARCB1. SMARCB1, the INI-1 protein is a subunit of the SWI-SNF complex, which has very important roles in epigenetic regulation, cell cycle progression, and crosstalk between cell signaling pathways. So alterations in SMARCB1 and loss of INI-1 have now been identified in a whole list of tumors. And you can see that, I just want to point out that the list of tumors here vary by age range. So malignant rhabdoid tumor and ATRT in particular present in this very young population, while entities like renal medullary carcinoma and epithelial carcinoma present in an older population. And then some of the others that are more recently identified present in any to an adult population. And there is a variation in what the genetic alteration shows within these different tumor types. Some have biallelic deletions and mutations, some have loss of heterozygosity, some have homozygous deletions. So the molecular actually varies depending on the tumor type. Interestingly, one of the more recent additions to this list, synovial sarcoma, shows epigenetic silencing of SMARCB1 and shows reduced expression in the tumors. So a little bit different process than what we're seeing in the malignant rhabdoid tumor and other classical rhabdoid type tumors. So I want to talk a little bit also about rhabdoid tumor predisposition syndrome, because as a pediatric pathologist, when I'm diagnosing these tumors, I have to make sure I'm in contact with the clinical team and make sure they're aware of any risk for a germline predisposition and that may affect other family members as well. So about 20 to 30% of rhabdoid tumors do show a germline alteration. And cases that have germline alterations are more likely to be cases where the patient has affected siblings, where the patient presents with multiple primaries, or where the patient has very early onset of a tumor. Interestingly, though, most of these are de novo, so most cases will not have other family members that are affected. The diagnosis of the rhabdoid tumor predisposition syndrome generally involves a combination of kind of classical sequencing methods, as well as deletion duplication analysis to make sure that both types of alterations can be detected. And we often test both the tumor and a normal specimen to identify which mutation was somatic and which was germline. These patients then have to undergo regular surveillance for the development of tumors, and any follow-up treatment or surveillance is designed to minimize exposure to radiation that may then lead to additional secondary cancers. So one of the more recent things that was identified about rhabdoid tumors of the kidney and of other locations is that they have a really simple mutational landscape. So the SMARCB1 mutation is really the primary driver mutation, and they really don't have a lot of secondary passenger mutations. And this has been demonstrated in studies of what's called tumor mutational burden, where we look at the number of somatic mutations over the total megabases of genomic data. So this is presented as mutations per megabase. And there have been a few studies that have looked at this in a variety of tumors that have included rhabdoid tumors, and consistently rhabdoid tumors show pretty much the lowest frequency of mutations compared to other tumor types. So thinking a little bit about what the function of SMARCB1 is within that SWI-SNF complex. So in the normal function of this complex, EZH2, suppression of EZH2 regulated methylation of histone H3 is the normal state, which leads to appropriate expression of tumor suppressors and cell cycle inhibitors. So this is when everything is appropriately balanced. You have appropriate expression of tumor suppressors and appropriate expression or progression through the cell cycle. When you lose that SMARCB1 by these kinds of mutations that we've talked about, you end up with overexpression of EZH2. And that leads to suppression of the tumor suppressor expression, which allows for cell cycle progression. Interestingly, I know this is complex, but I'm going to egregiously simplify these very complex pathways. SMARCB1 is involved in multiple different pathways that are associated with cancer. So it's involved in the aurora kinase pathway, cyclin D1, and retinoblastoma pathways, sonic hedgehog, MYC, Wnt beta-catenin. And so when we combine this concept of a very low tumor mutational burden with one primary driver of oncogenesis, where that driver of oncogenesis is involved in so many different pathways, this suddenly becomes a really attractive target for targeted therapies. that's also attractive due to the fact that the current therapies that we have for rhabdoid tumor are particularly toxic, because we're really throwing the kitchen sink at these things because we don't have anything good to treat them. And so there are a number of areas that are under investigation for targeted therapies, including inhibitors of that EZH2, histone deacetylase inhibitors, CDK4, Aurora A kinase, and DNA methyltransferase. And so I'm just showing this to demonstrate how many different pathways are being investigated and how many different drugs are in investigation for this, because this is a really desirable area to treat. Even though these are rare tumors, they are so incredibly aggressive, and we've made literally no progress on them in the last 10 to 15 years. So there are a number of ongoing studies that including within COG, that we're hopeful about, but this is an area that remains to be seen what will happen. Okay, moving on to something far less aggressive. This is a 2-year-old with a cystic renal mass, and here you can see the gross image. This is pretty unimpressive cystic lesion, very little to no solid component. Histologically, we see these cystic spaces. Within the septa, there's some chronic inflammation. The epithelium of the cystic spaces is a little kind of prominent hobnailed. There may be some stroma here. Looking at a higher power, we again see that kind of hobnail epithelium and a little bit of spindle cell stroma. So in the pediatric population, this is considered a pediatric cystic nephroma. So historically, we thought that pediatric cystic nephromas were part of the nephroblastic tumor family, that the spectrum went from a completely solid Wilms tumor to what's called a cystic partially differentiated nephroblastoma, which is a cystic tumor that still has nephroblastic elements within the septa, to the pediatric cystic nephroma, which shows none of those nephroblastic elements. However, we were wrong. So it turns out that pediatric cystic nephroma is actually completely distinct from the nephroblastic tumor family and is actually part of the Dicer-1 tumor family. And this was discovered as reports were made to the pleuropulmonary blastoma registry. Pleuropulmonary blastoma is a cystic lung tumor that's seen in kids, and it has a very histologically similar appearance to cystic nephroma. So this is an example of a case of pleuropulmonary blastoma, which has these thin septa with maybe some spindle cells in the septa. And so through this PPB registry, they found that 12% of patients who had PPB either had themselves or had a family member with cystic nephroma. And so this was how this was identified, that cystic nephroma is actually associated with this PPB family of tumors. And so pleuropulmonary blastomas and cystic nephromas, and now a whole number of other tumors, have been found to have germline and somatic mutations in the Dicer-1 gene. So Dicer-1 is, the Dicer-1 protein is involved in the processing of microRNAs. And so if you remember, microRNAs are segments of non-coding non-coding RNAs that are transcribed into an RNA but are not translated. And these go through some processing steps, and Dicer-1 is involved in that processing. And these mature microRNAs then bind to complementary mRNA sequences and prevent protein synthesis. So mutations in Dicer-1 actually have a very interesting pattern. And so it's been identified that the germline mutations are usually loss of function mutations, so nonsense mutations, frameshift mutations, deletions, things like that. And those are scattered all throughout the length of the gene, and those are seen on the bottom of the diagram here. However, the somatic mutations are generally localized to these hotspots in the RNase 3b region. Now, this is not 100%, and there is some overlap, but in general, mutations follow this pattern. It's also important to note that there are totally sporadic cases with somatic mutations only that do not have a germline mutation at all. So just because you have a DICER1 mutation doesn't mean it's a germline DICER1 mutation. Or that just because you have a DICER1 associated neoplasm, it doesn't mean that you have a DICER1 tumor syndrome. So cystic nephroma is now identified to be one of the major criteria for the DICER1 tumor syndrome. And so patients who have a pediatric cystic nephroma are recommended to undergo genetic counseling for DICER1 tumor syndrome. The other common tumors that we see with this include the PPB that I mentioned, ovarian sertoli Leydig cell tumors, uterine or cervical embryonal rhabdo, multinodular goiter, and again, this is a growing list of tumors that are associated with DICER1. So I want to circle back to CPDN, or that cystic partially differentiated nephroblastoma, because it does remain a gross and histologic mimic of cystic nephroma. These cases, CN and CPDN, can be indistinguishable grossly. They can both have really similar appearing stroma with cells, this kind of condensed stroma that surrounds the cysts. However, the cystic nephroma should not have these immature nephroblastic elements at all. So if you see immature nephroblastic elements, it's more likely a CPDN. And this has been demonstrated molecularly as well. So cases of pediatric cystic nephroma were compared with cases of CPDN, and most of the cases of cystic nephroma did carry DICER1 mutations, and none of the CPDN cases carried mutations. It's also important to note the difference between adult and pediatric cystic nephroma because these are also distinct. Pediatric cases have more of a male predominance while the adult type has more of a female predominance. The pediatric cases are more likely to be poorly encapsulated and more complex. The pediatric cases don't have that classic ovarian type stroma or the wavy collagen. And ER and inhibin staining can be somewhat helpful, though ER is positive in both. It's generally stronger in the pediatric cases, and both are the pediatric cases are negative for inhibin. And the adult cystic nephroma is now classified as part of the mixed stromal and epithelial tumor family. So here's a couple of examples. This is an adult case that demonstrates the wavy ropey collagen and the ovarian type stroma and positivity for both ER and inhibin. And then this is a pediatric case that shows, again, some stroma, but it's not exactly the ovarian type stroma, and it is positive for ER, but negative for inhibin. Sets of these cases have also been studied molecularly and also demonstrate that the adult cases, in most cases, do not carry a DICER1 mutation. There are rare reports of adult cystic nephromas that do carry DICER1, and it's thought that these probably represent pediatric type tumors that were just not recognized during the pediatric age. I also want to mention as part of this section, anaplastic sarcoma of the kidney. So while cystic nephromas are a totally benign tumor, there are rare aggressive cases that do undergo sarcomatoid transformation with overt anaplasia. And these cases look incredibly similar to the type 3 PPB, which is the solid type. And they demonstrate a similar aggressive appearing tumor with heterologous elements, including cartilage and skeletal muscle. These cases of anaplastic sarcoma have also been shown to carry DICER1 mutations. So these are incredibly rare, so there's not a lot of information on when and how these progress from CN or if they even really do. However, there's at least one good report in the literature of a case where a child was imaged and had a very benign appearing renal lesion that was cystic that over time grew and became more solid, and when removed was an anaplastic sarcoma of the kidney. So that's some decent evidence that this did progress from a more benign version. So a lot there about pediatric cystic nephromas, but the real take home is these are different from adult cystic nephromas, they're different from CPDN, and they are associated with the Dicer-1 tumor syndrome. Okay, our next tumor, speaking of anaplasia, is really ugly looking. We have big polygonal atypical cells, some that are really hyperchromatic, some atypical mitoses. Here are some monster cells, a giant mitosis that you can practically do a karyotype on. So really ugly tumor. So this is a Wilms tumor with diffuse anaplasia. So about 4 to 10% of Wilms tumors do have anaplasia. Anaplastic Wilms tumors are not necessarily more aggressive in behavior, but they are associated with chemotherapy resistance and thus are treated with more intense therapy. Anaplasia is associated with somatic TP53 mutations, but TP53 IHC is somewhat useful. We sometimes use it when we're not sure if something is anaplasia or not. It doesn't quite meet the criteria, but it's concerning. But it can be normal in cases of anaplasia, or can be positive in areas of nuclear unrest, which are areas that don't meet the criteria for anaplasia, but are more atypical than kind of normal Wilms tumor. So TP53 mutations, there have not been a lot of studies into what is actually going on in these tumors. There was a study of about 40 cases of diffuse anaplastic Wilms where they looked at whether they had TP53 mutations or 17p loss. And they found that 25 cases had at least one or the other, and 20 of the cases had both. When they looked at these cases by CGH array, the ones that had TP53 alterations showed more copy number alterations. And they also looked at gene expression profiling, and the genes that were differentially expressed in the mutated group were actually enriched for genes that participate in the cell cycle. So in these graphs here, we can see within this diffuse anaplasia Wilms tumor group, the ones that had the TP53 mutations fared worse than the ones that did not. Currently, testing for TP53 is not part of the workup for anaplastic Wilms tumor, but there is a new COG study that just opened, I believe it was last Friday, 2 Fridays ago. And this looks at the treatment of newly diagnosed diffusely anaplastic Wilms tumor and relapsed favorable histology Wilms. And they're really looking to evaluate the effectiveness of treatment intensification for these cases. But there's also an exploratory aim to look at TP53 alterations in these cases and correlate that with outcomes as well. And as part of my role as a young investigator, I'm also going to be looking at these cases and evaluating the volume of anaplasia to determine if there's a difference between low volume and high volume anaplasia and outcomes. Within Wilms tumor, I also want to mention loss of heterozygosity. So loss of heterozygosity can occur when you have loss of one allele completely, when you have focal deletion of a portion of one chromosome that leads to loss of an allele, or when you have loss of one copy and duplication of the other copy. So even though you have 2 copies, they are exactly the same. So all of these result in loss of heterozygosity. In Wilms tumor, loss of heterozygosity is pretty common, seen in about 10 to 20% of cases, and a combined loss of 1p and 16q is associated with a worse prognosis. And COG has actually done studies and published data showing that increasing the therapy for patients with this LOH of 1p and 16q results in better outcomes. And that's demonstrated here. So this is event-free survival for patients with stage 1 and 2 and stage 3 and 4 Wilms tumor. And this is comparing, the blue line is patients who had that treatment intensification versus patients with the same loss of heterozygosity who did not. And so there's a significant difference at both low and high stage, and shows the benefit of that treatment intensification. There's an additional marker of the gain of 1Q in Wilms tumor is actually more common than the loss of heterozygosity, seen in about 14 to 39%, and often co-occurs with that loss of heterozygosity. I'm sorry, that's supposed to be 1P. And so this is most apparent in stage 1 and stage 4 patients. So here you can see 1Q gain versus no 1Q gain, and you can see a worse overall, worse event-free survival and worse overall survival in the patients who had the 1Q gain. So this is another marker that is now included in the evaluation of loss of heterozygosity and chromosomal aberrations in Wilms tumor. So as I've been involved in the renal tumor committee through the Children's Oncology Group, one thing that has really struck me is how the Children's Oncology Group focuses on a balance of therapy. So most treatment protocols are aimed at making sure that the treatment is sufficient to treat the cancer. However, when you think about pediatric patients, they're going to carry the sequela of their therapy for years to come, assuming they survive their cancer. So the Children's Oncology Group really focuses on both the maximization of response as well as limiting the negative effects of therapy. And what that means is there's this constant tweaking of, are we treating too much? Is there a subset of patients that we can back off therapy? And it results in a large stratification of patients, and so you end up with more complex treatment protocols, but you also end up with much more precise treatment. So one of the areas that's been demonstrated is in a group called very low risk Wilms tumors. So these are patients who are stage 1 with favorable histology. Their tumor weighs less than 550 grams and they're less than 2 years of age at diagnosis. These patients show a really great overall survival, and they have been able to reduce their treatment down to nephrectomy with no additional chemotherapy. However, there was a small subset of patients who did develop subsequent relapse or metachronous primaries. And one of the common things that was identified in this group was 11p15 loss of heterozygosity or loss of imprinting that was associated with this relapse. And so yet again, they've been able to stratify this. So even in the very low risk group, there's still this small group that actually does get chemotherapy because they're at a higher risk for relapse. So I think this nicely demonstrates how we try to balance reducing treatment, but making sure we're giving just enough treatment. Okay. So this is our next tumor. This is a 2.5-year-old girl with a renal mass. And you can see that, again, we have sheets of tumor cells, and we have this kind of fine background network of vasculature, almost a chicken wire pattern. And the tumor cells themselves have this clear to vesicular chromatin and pretty indistinct kind of fluffy cytoplasm. And at higher power, we see there are multiple mitotic figures, and again, we see that vesicular chromatin. So this is consistent with a clear cell sarcoma of the kidney. These are again probably the second most aggressive of the renal tumors. They generally arise from the medulla and are generally pretty large at diagnosis. The histology can vary quite widely and make these a really difficult tumor to diagnose because they can be in sheets, to nests, to cords, to a spindle cell variant. They can have microcysts with variable different types of background matrix. So these can be really challenging. There are some immunostains that are somewhat helpful, most of which were originally identified based on gene expression profiling, and those include BCOR and cyclin D1, and there is a newer marker called NGFR, but all of these suffer from some limitations in specificity. So clear cell sarcoma of the kidney is the second most common pediatric renal tumor. These are more common in the 2 to 3 year age group and have a bit of a male predominance. And unfortunately, over half of these present at stage 3 or 4. We have made some inroads in treatment to these, and now survival is about 70%. So not wonderful, but not as awful as rhabdoid tumor for sure. So the really interesting thing about clear cell sarcomas is for a long time we've known that there's this recurrent translocation between chromosome 10 and 17 that results in this YWHAE NUT2M fusion. However, this was only identified in a subset of cases, probably around 10 to 12% of cases. Until relatively recently, as testing moved to NGS, they actually identified these recurrent internal tandem duplications in the BCOR gene. And these are actually present in up to 85% of cases. So it really explains the vast majority of the cases that were negative for the originally described fusion. And these internal tandem duplications occur at the very end of the BCOR gene and the very last exon. And in this diagram here, the green sequence is the normal wild type sequence, and the red sequence is what has been copied and then inserted right beside it. And that's why it's called an internal tandem duplication. These internal tandem duplications are always in frame, and they're always located in the same location at the very end of the gene. These internal tandem duplications are mutually exclusive with the fusion, and so together these really explain most of the cases, not all, but most of the cases of clear cell sarcoma. And this BCOR internal tandem duplication results in BCOR overexpression. So interestingly, as this work was being done and these were being described, it was noted that there were some extra-renal pediatric tumors that had very similar cytomorphology. And this included a subset of undifferentiated round cell sarcomas, as well as primitive myxoid mesenchymal tumor of infancy. And it's been found that a high percentage of these cases also have the BCOR internal tandem duplication, and also a minority of them have the YWHAE NUT-M2 fusion. And then taking that a step further, based on gene expression profiling, all of these cases really cluster together with clear cell sarcoma of the kidney, as well as other BCOR fused sarcomas, like cases that have BCOR CCNB3 fusions. And since this time, there have also been cases of clear cell sarcoma of the kidney that have BCOR fusions, like the BCOR CCNB3. So this has really been demonstrated to be a whole linked family of tumors. And I just wanted to show some really nice pictures of the cytomorphology that I was talking about. So these are all examples of undifferentiated round cell sarcomas that either have fusions or BCOR internal tandem duplications. And you can see that there is overlap, particularly with that fine vascular network and the cytomorphology of these cells. I will say that the cytologic appearance and architecture is quite variable, but that's also the case for clear cell sarcoma of the kidney. These are some cases of the primitive myxoid mesenchymal tumor of infancy. And again, you can see some overlap with the cytomorphology, particularly with these that have the round cell morphology. And then these are three cases that demonstrate a clear cell sarcoma of the kidney case, a BCOR MAML3 fused sarcoma, and an extrarenal BCOR CCNB3 sarcoma. And again, we see that similar cytomorphology and this kind of background delicate chicken wire vasculature. So to date, there have been additional tumors that have been identified with BCOR ITDs and or fusions, and these include endometrial stromal sarcomas, CNS high-grade neuroectodermal tumors, rare cases of ossifying fibromyxoid tumor, and rare cases of APL. So this is, again, a growing kind of family of tumors. I think it's important to kind of point out how do we go about diagnosing these now that we know that there are a variety of alterations. Well, there is a commercially available assay that looks for the ITD only, and this is based on PCR across the region and looking at the length of the amplification product by capillary electrophoresis. But the limitation is it only detects the ITD. It doesn't detect either the YWHAE fusion or any kind of BCOR fusions. And then FISH is limited by looking for specifically for the marker or the gene rearrangement that you're asking about. So you can do FISH for the YWHAE rearrangement or for the B-Core CCNB3, but basically these would be 3 separate tests that you would have to do for one tumor type. And these could be done kind of in a sequential manner, with the B-Core ITD being the most common. That would probably be the one to start with. But now with NGS being much more readily available, you could use NGS-based panel testing to detect both the fusions and the ITD at the same time. Okay, and then the last case that I have is kind of a twofer. So on the left, we have a 1-week-old patient with a renal mass, and on the right, we have a 2-month-old patient with a renal mass. The tumor on the left is characterized by kind of long sweeping fascicles. On high power, these tumor cells are spindled and have a relatively low mitotic rate. The nuclei are quite bland. On the right, we have a tumor that is somewhat fascicular, but it's much more, the cells are packed in a little tighter. The nuclei are a little more plump. The mitotic rate is definitely higher. And we have these kind of thin-walled vessels that are kind of that hemangiopericytoma-like vasculature. So these are both consistent with congenital mesoblastic nephroma, with the one on the left representing the classic type and the one on the right representing the cellular subtype. So there are some differences in the classic versus the cellular. They make up a similar proportion of overall cases of CMN. The classic usually presents within days to weeks of birth, whereas the cellular presents within 3 to 5 months of birth, so a little bit later. The classic case is pretty much never aggressive in behavior and is treated with just resection only. The cellular type is only very rarely aggressive, and so most of these cases can also be treated with resection only, but there are occasional cases that do present at a higher stage and require subsequent chemotherapy. I mentioned the differences in histology. I'll also mention that the classic subtype generally has a more infiltrative border despite being a more well-behaved tumor, and its border tends to have these finger-like protrusions into the surrounding renal parenchyma. It also often shows nodules of cartilage at that interface. And then the cellular subtype generally has a more pushing type border. I think we're all familiar with the fact that the cellular subtype has an ETV6 intrec3 fusion that is characteristic of this tumor. And the molecular underpinnings of the classic subtype have really been unknown until very recently. There's also a mixed subtype that can have a really variable appearance and can have like really discrete, distinct areas of the classic versus the cellular, or it can be a really hard combination to tell apart. And a subset of these carry that ETV6 intrec3 and a subset are negative for it. So what's actually going on with the molecular? So really in the past 2 years, this is an area that has exploded in information. And we actually now understand what's happening in the vast majority of those classic cases that were negative for the ETV6 intrec3 fusion, as well as those mixed cases that were negative and rare cellular cases that were negative. So in the past couple of years, various groups have described variant intrec fusions. So intrec3 partnering with a different partner, intrec1 fusions, fusions with RET, fusions with BRAF, and then also BRAF compound deletion duplication events where you delete a big portion and actually duplicate a different portion. And then EGFR internal tandem duplications, and these are particularly seen in the classic and the mixed subtype. Kind of replicating what happened with the clear cell sarcoma, a very similar spectrum of variant alterations are now being found in infantile fibrosarcomas and related tumors. I will also take this moment to mention that even though these are generally benign tumors, those rare, more aggressive cases have historically gotten kind of classic cytotoxic chemotherapy. However, now that we have targeted NTRK inhibitors, cases with the ETV6 NTRK3 or these variant NTRK3 or NTRK1 fusions are now able to be treated with those TRK inhibitors. Even though it's not going to be a huge population, for a small number of patients, that's going to make a huge difference. Okay, so coming to the end, I just wanted to wrap up with a timeline just to really hammer home how much we've learned in the past 3, 5, 10 years. So most of what we've talked about today has really been in this area, and much of it really in the past 5 years. So I think that's incredibly exciting and really impressive. And I think we're going to continue to learn more about all of these tumors. And so just to wrap up, pediatric renal tumors are extremely diverse in their clinical behaviors, their histologic features, and their molecular features. And development and carrying out therapeutic studies is a continued challenge just because we don't have many of these tumors to actually study. And I also just want to make it clear that NGS is really starting to play an increasing role in the diagnosis of these tumors. A lot of these, especially like the congenital mesoblastic nephroma, we would do FISH for the ETV6 NTRK3, and if that was negative, then it was kind of like, oh, okay, well, it's negative, so, and that's it. So, but now we actually have the pathway to further characterize these. And I think, you know, as we continue to further characterize these, we may get additional information about clinical subtypes and differences in behavior based on these molecular subtypes. And again, our knowledge has grown so significantly in just the past few years and is expected to continue to grow. And I just want to point out that the time in which this knowledge has grown probably outdates some of our textbooks that we use pretty constantly. So if you go back and take a look at your favorite renal textbook and see when it was published, I guarantee that a number of these things that we've talked about today have come to light since that publication date. So hopefully this talk has helped you keep current in the area of pediatric renal tumors and given you a little bit of insight into what's going on in the COG. And with that, I want to thank you for your time, and I'll take any questions.
Thank you so much, Dr. Treece. We do have a couple of questions from the talk, starting off with Dr. Howell, who says, as usual, outstanding talk. Is it possible that the greater prevalence of translocations in pediatric versus adult renal cell carcinomas reflects greater cell growth or differentiation in the pediatric group? And then his corollary is translocation located, TRCC, sorry, let me not mess it up, particularly prevalent in the first 5 to 10 years of life when the kidney is actively growing and approaching the adult histologic pattern.
Yeah, I think that's an interesting point, and probably I would think there's something to that. You know, I think in the adult population, you get such a dilution of things that are secondary to a patient's exposure over time, whereas in the pediatric population, the tumors we see are more likely to be something that has gone wrong in a native developmental process. So I think you're probably correct about that.
Okay, the next question from the chat is from Dr. William Jack. From quite a bit earlier in your talk, I'm interested in the current trials with immunotherapy and translocation-associated renal cell carcinomas. Do these tumors show higher mutational burden than, e.g., rhabdoid tumors? Are there other examples of successful immunotherapy in translocation tumors, other sites, or adult translocation tumors of kidney?
That's a good question, and I am not as familiar with the in-depth of the translocation renal cell carcinomas. As far as the tumor mutational burden, I did not find a paper that directly compared rhabdoid tumors with other renal tumors, but in general, the adult carcinomas do tend to have a higher tumor mutational burden. So I would guess that they do have a higher tumor mutational burden. And as far as the use of the checkpoint inhibitor therapies in other similar tumors, I'm just not familiar with that. I don't know what the literature is on that. I apologize.
Okay. Next is from Sarah Wobker, who's one of the co-organizers of Virtual Pathology Grand Rounds. Wonderful talk. Thank you. With the TFE3 SFP tumors with mesenchymal features, do you know if there's any overlap with TFE3 associated picomas? I think these have been rarely reported in PEDS population.
I believe there is. I think that's an area that the surface is just beginning to be scratched. There are a couple of papers out there about that, and so I don't think the full spectrum of that has been elucidated yet. So I think there probably is some overlap there.
All right, so I don't see any other questions, so I will thank you again, Dr. Treece, for a wonderful talk, and thanks to everyone for attending. Have a good Friday, everyone.
Thank you for having me.